Okay, so let's see. The scoring is happening.
Just looking at the names. Yeah.
There we go. Yeah. There we go. A bit more down to see for the camera.
Francois Marais is in my house in Cardiff now. Right, so you might be looking. I've never met him. It's staying in my.
The different Francois Marais.
Yeah.
So firstly, welcome everybody, and a special word of welcome to
Thank you so much.
Professor Steve Rollnick. Lovely to have you here as part of our monthly FACE seminar, and this, yeah, also a lovely excuse when you reached out the first time saying you're coming to Cape Town. We thought, yeah, this is a great opportunity. Why not? So I mean, I suppose a lot of people know you and your work. And maybe I'll leave it to you to introduce yourself to what you're doing, what you're busy with presently. But over lunchtime, you mentioned something about being a what is the word you said about academia, that you've recovering academic, yeah. And when I looked at your bio, it's quite impressive, and it speaks to a lot of academic trauma that you've been over the years.
Well said.
I think some of the trauma we still a lot of us can relate with. But I mean, in a more serious note, I mean, obviously knowing that what you have done, a lot of people probably know you mostly for your work on motivational interviewing. But what was also lovely to see is that there's a lot of other things that you have been busy with. I mean, it's also and we would be interested to know about your journey from Cape Town to Cardiff, sea to sea, if you want, how that has happened. So at the moment, you're an honorary distinguished professor in the Department of Primary Care and Public Health at Cardiff University. You've spent 16 years in the UK National Health Service, which is also quite interesting perspective to think about where we're at in South Africa, also with the proposed NHI and universal health coverage. You've worked with Bill Miller on the motivational interviewing books. And several of those books have been published over the years. I think the first one was, I said, year 1991. So that's also been some time that you've been also investing yourself not only into the practice but also the teaching of motivational interviewing practice. And yeah, I mean, there's obviously a lot one can still add to that. But what is you're saying you're a recovering academic at the moment, and you're switching from healthcare to sports, and that is I'm sure that's something that a lot of people might pique their interest. So just a word on housekeeping. I mean, we've got it's a hybrid meeting, so we've got people online and in the room, and I'll be monitoring also online, making sure that those that are online are not left out of the loop. But those that are here in person, thank you for making the time. There is some snacks, and you know where the bathrooms are. What we'll do is we've got a QR code, and my sincere appreciation to Manisha and Fundi also for the logistics. There is a QR code for CPD points, so which displays at the moment on the screen. And in the chat, I hope all that are online, I will post it later again. There's also a direct link to the Google form just to capture your CPD attendance. And then, yeah, it's a pleasure to hand it over to you, Stephen. Thank you again for making the time.
Pleasure, really.
And a sneak preview also that this is the seminar, and next week there is a workshop that is about the same venue 1 week from here, but this today is in a way to maybe set the scene and connect with new and old colleagues. Yeah.
Yeah, and this is, I mean, I guess I prepared it more as a lecture today, but we can please just interrupt and greetings to the folk that are online. Few words about myself, and then you'll go bong bong with it.
I'll do the bong bong.
Thanks. I grew up here and then worked as a clinical psychologist in the British NHS. Then I was a professor in the medical school with a special interest in communication and tough conversations and tough consultations. Worked very closely with Chris Butler, who is coming out here quite soon. He's a very close personal friend, and hope you get a chance to meet Chris. He's a family physician. And then, like it or not, I was a co-founder of this thing called motivational interviewing, which I'll talk about. And then in 2014, I think, that's just over 10 years ago, I retired and looked at tough conversations in school and in sport. We tried to write a book, or I did write a book in each, which was tough. And then I thought I will just do what I love, which is sport, because I'm a Cape boy who grew up in Newlands. And so I work in now, I have a job in an elite cricket team, and I work for the Football Association, the Premier League, and coach development. So there's all sorts of experiences there. But when I thought of coming out, I thought I would tackle something that's bugging me at the moment. So I've not spoken about this before, putting it together quite the way I'm going to today. And that's exciting for me. I hope it'll be of interest to you, because I'm going to be talking about whether advice giving can be merged with something a bit more complex like motivational interviewing. And I'm going to reach the conclusion that they can be. And I'm going to explain why I think these are two very happy siblings. But unfortunately, when I start talking to you a little bit about the history, you'll see they weren't happy siblings to begin with. And I think in that story of the origin of motivational interviewing, half of which was here in Cape Town, is an interesting, there's some interesting lessons along the way. And my God, it's many years. But I'll get back to quite how many in a moment. But before we start, I suppose the question that I've been puzzling with, that I wonder how you feel, which is, how often do you notice people being given advice in everyday life? I'm puzzled by this because I was never taught how to give advice. How well does it land? If it's so commonly used, how well does it land? And then this one, which came in the form of a call from, what was his name will come to me, but he's a very accomplished soccer coach, Dutch guy, Jan, and I can't remember his second name. But boom, 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 boom on my machine. And I know him reasonably well over the years. Yeah, what do you want, Jan? He said, Steve, I want to ask you a question. And I said, yeah, Jan, and he says, when did you last ask someone for personal feedback? And I went, So he says, I see, Steve, so it's fine to give people advice, but you don't so much like to receive it. And then he told me the story of his own personal development. He's a very elite football coach, a soccer coach. But if you look outside of his second name's bugging me that I can't remember, forgive me. But if you look outside of clinical work in everyday life, advice giving is quite widespread. Yeah. And it's often unwelcome. And it's mostly well-intentioned. So this is the puzzle. Everyone seems to do it. It kind of trips off the tongue. And it seems easy to do until you look at the impact. Like someone said to me, it was 2 days after my dear old dad died. Like he was 97 and he was my best buddy, right? And someone said to me, I knew quite well. Well, see if you can live that long, Steve. Yeah. That comes from a really good place in his heart. And I wanted to slap him. You know what I mean? No. Well, he was giving me advice about how I might want to lead my life.
It's not advice.
Hey?
It's not advice.
Well, it was, no. See if you can live that long, Steve.
That was a challenge. It wasn't saying eat your vegetables, Steve.
No, I suppose so. Anyway, it landed not that well. Okay. Do this, do that, or if you don't, then this, or no, not like that, like this. That's what I'm talking about. And the experience is so often unwelcome. And the hit rate is very low. So it's something that persists a lot that has a low hit rate. You know that kind of thing, like you're doing a driving lesson with your kid. There's a good scenario. And you give advice here and then it ends up with the kid screaming at you saying, can you stop shouting at me? Do you want to drive instead of me? You know that? Yeah, or teaching a kid to ride a bike and you go, your heart's in the right place. You get, it's my bike. Let me ride my bike the way I want to. So, okay, people seem fine to give advice, are less keen to receive it or ask for it, which seems like a reasonable. And kind of spare a thought for children who, by the time they enter adulthood, they've been showered with advice from all sides, warnings, threats, loving messages as well, about why and how they should change their attitude and behavior. And I can't help noticing what feels to me like a paradox, which is it's widely used and ineffective. You could call it an advice paradox. Okay. Here's a good example. I was in a UK Soccer Premier League academy where they breed these wizards. Yeah. And the coach I was mentoring said, Steve, do what you like. They were playing a game and do what you like, speak to whoever you like. And I said, could I speak to 3 players after the game? He said, yeah. And I watched the coaches, and the coaches are from the side of the field emitting advice at a phenomenal rate, high energy, high adrenaline. And I got hold of these 3 guys afterwards and asked them, how much of the coach's advice did you notice during the game? Yeah. So that it does that explain to me, well, why do we keep doing it? And yet, it's like the exception proves the rule in the sense that we can all recall someone giving us some advice that was really incredibly useful, even if it's in retrospect. So Ken Robinson is someone worth looking up on YouTube. He was an educationalist, and he made a comment. They spotted something in me that I hadn't noticed in myself. Now, if that's the end of the rant on advice giving, I wanted to turn now to motivational interviewing, and I should check the time, Klaus. It's 1:15. Maybe I should just breathe or have a sip of coffee.
Would you like some advice?
You don't mind. Are the folk remote doing all right? We don't exchange with you guys, do we? But still.
They can.
Yes, they're
They're doing stuff.
We are very happy.
Oh, are you? Oh, brilliant. Oh, brilliant. And is Francois Marais there? That would make me happy because he's in my house in Cardiff. Show me the cat, Francois. No, that was a joke. That was a joke. I see, so they can see. So, all right, okay. So I'll switch to motivational interviewing now. Okay. But it was bombarding people with advice that I now realize was the spark that gave rise to motivational interviewing. And arriving back home now, I counted the years, and it's 49 years where I saw advice giving being taken to new heights. And this was, and I was a nurse orderly here in William Slater Hospital in the corner of far end of Rondebosch Common. And it was the spark that set motivational interviewing alight for me and matched the experiences of my friend and co-developer, William Miller, who's based in the United States. It was an inpatient addiction unit, yeah? And patients were confronted consistently daily for 3 weeks with advice about the need to do this, do this, do this, do this, do this, do that. I don't know whether I saw this at the time or whether this is just retrospective. It's probably a mixture. But the more we confronted, the more they resisted. And they were seen and described and discussed by the staff as having poor motivation, resisting treatment, and being in denial. That was the coffee room conversation. And then there was a man called Anthony. I was running an outpatient group for young alcoholics. He never said a word during the group, but I had watched him over the course of his inpatient stay. And he basically walked out and shot and killed his wife and then committed suicide himself. Yeah, basically that's what happened. I left under difficult personal circumstances, I reckon, and ended up in Cardiff and training as a clinical psychologist. And in 1983, I saw a paper called Motivational Interviewing. And then 5, 6 years later, and I started practicing it, and I realized that there was a different way of going about helping someone consider change than persuading, haranguing, giving them advice, and so on. Then I met the guy who wrote the paper, who was shocked that anybody had shown any interest in this. He wasn't aware of this. This was in Sydney, Australia. And so we wrote a book then, as you said, and that's been decades of friendship and collaboration and development. And he's a bit of a nerd with numbers, but over 2,500 randomized trials have been done on this. So it speaks to a need. I think that's what's happened, which is practitioners and people notice that there might be a more useful way of going about helping people face change. I think you could state that negatively and say they notice the damaging and unpleasant effects and conversations that can take place if you harangue people into change. I think that's what's happened. Okay. He remained fairly firmly as a psychotherapist, and I felt it was useful in healthcare. So of the two of us, it's me that moved more into healthcare. And over the decades I've been back here, I was involved in the HIV pandemic and setting up organizations in Africa and Southern Africa. So, my life took a kind of a different turn. And now more recently in schools and sport, and I can see the connections between the conversations in William Slater and conversations that happened right on the sports field. Do I sound a bit like a goofy old man in saying that it's possible? You can sometimes get to see things very simply, and then maybe you realize you're starting to dement and it's not. But I tend to see things a little bit simply, maybe. But look, what's the essence of this motivational interview? It's instead of persuading someone to change, you try and bring the best out of them and come alongside them and help them make the wisest decision for themselves. And that is not unique to motivational interviewing, because the words I've just used just sound like being very helpful, don't they? I think what we've contributed is the specific skills that really make that sing and really make that conversation go brilliantly. And we do know about that, and I can speak to that. So we dived into the detail of how those conversations go well and not so well. But in those days, it was clear enough. Giving advice was a very poor relation to motivational interviewing. And then to some extent, there was, I think, looking back, a professional arrogance there on our part and my part, that we found a way that's better than this. Okay. And we documented the traps you could fall into if you tried to persuade people. The expert trap, which I think you can all imagine what that is, the confrontation denial trap, which is what I saw in William Slater. Labeling and blaming people doesn't get the best out of them. But look, there's no better way to capture this than to show you how we saw it at the time. And you'll recognize all of these traps in the video that I'm going to put on. And it features Chris Butler himself. And you'll see the two of us as young, kind of ambitious guys, God knows, early 90s. So what's that, 30 years ago? I can't, yeah. But the purpose of this video was to illustrate how advice giving could go wrong. Okay, it wasn't an attempt to be clinically realistic. It's made a little bit extreme. Chris trained in drama in Grahamstown. Okay, and you can see he's a very good actor.
I want to make sure that I share it with the sound here.
Okay.
And then it's at 6 minutes 16. Is it coming through? Okay.
I didn't hear you.
Can I, I think it's at this point.
Yeah, it looks good. Yeah, it's good. Or maybe it goes on for about 6 minutes. I might stop it
Mr.
before.
Harvey, I just wanted to talk to you a bit about the medication.
Yeah.
The little white tablets, it's a water tablet, one each morning. Okay. Little blue tablets, it's called a beta blocker. I want you to take one in the morning, one in the evening. You've got your spray, you've got your nitrate tablets, and that again is twice a day. Okay.
The water tablets, do they make me pee or stop peeing?
They make you pee, so
right,
that gets rid of fluid, takes pressure off your heart.
Right.
Okay. So that's your medicine sorted out. What I want to do now is to talk about some of the things that might help prevent you having another heart attack, because
Sure.
tablets can take us so far.
Yeah.
What you do with your life is perhaps more important than the tablets.
Right.
And as I'm sitting here, to be honest, I can smell a bit of smoke about you.
Yeah.
You still smoking?
I still smoke, but not as much as I did.
Why not as much? How do you mean? How many do you mean?
I don't know, about 10,
10,
15 maybe
10, 15
a day.
Okay.
Yeah.
Look, I've got to say that, smoking is the worst thing you could possibly be doing. It is the absolute worst thing that you can do after a heart attack. Worst thing you can do at any time, but right now for you, it's bad news. And in a way, you're very lucky that we're having this discussion now, because I've
I
got
understand that, yeah.
Good. I'm glad you're taking it seriously, because, we got to knock it on the head straight away.
Sure.
I've got a quit smoking clinic that I run in this very hospital, and so happens that tonight we're having a meeting where people can come and plan their quit date.
Yeah.
I mean, it's my experience, the only way to sort this thing out, get a bit of support around you, set a quit date and go for it.
Yeah.
So it's at 8 o'clock.
Yeah. Well, two things. One is I've tried quitting,
Uh-huh.
and that didn't work.
Uh-huh.
The second thing is I'm kind of tied up this evening, so I
Right.
can't make it tonight.
Look, and it's a serious problem, you know, there
Yeah.
can be few things more serious than your health, and, you know, I think you got to really just
Yeah.
take.
It kind of helps me as well. I feel that, you know, smoking kind of helps me to handle the stress, but it's been pretty stressful these last few months.
Yeah, it might help you feel better, but it's doing your heart no good. And my you know,
I think I should quit, you know.
I agree with
but
you.
I can't
agree
just,
with
as
you.
you put it, knock it on the head.
Look, I've been
And I'm
through
tied
this.
up tonight, so I can't.
I've
make
been
it
through
tonight.
this a
Yeah.
lot with a lot of people. Cutting down, and that simply does not work. You've got to set a date and stop, and that's it. And you've got a great opportunity tonight
Yeah,
to
well, I've heard that there are different ways to approach it, and some people would say that you can actually cut down.
Well,
and eventually then
you know,
stop.
that's not what I would recommend. I'd recommend that we sort you out perhaps with a patch or some
Yeah.
tablets, and you know,
Tablets.
Yeah.
I have a whole cocktail of tablets right now. I
Yeah.
mean, is there going to be some kind of reaction?
Well, you know,
Are there going to be
there's
side effects?
there's always side effects, but there's no gain without pain here. We've got to kind of tackle this thing very seriously now.
Yeah, I agree. I should stop smoking.
Okay, so we'll see you tonight.
Can't make it tonight. I cannot make it tonight.
Well, look, what about the alcohol at the moment? How much are you drinking?
I drink with my meal,
About how much?
half a bottle.
You can see how that's going to roll. There's alcohol, there's diet, and how widespread is that way of being with people? You reckon?
Very, very,
Really
very.
widespread.
I was doing it just now.
Sorry?
I was doing it just now in the clinic. This woman took prednisone for a year. She said it helped her fibromyalgia. And knocking on its head. You can't do that. It's going to cause this.
Do it every day with my.
And I watch sports coaches. Question I often ask myself, I don't actually often ask them this, is where's the magic? Because it's clear the magic is inside his head. And the problem is just to lift the lid on the patient's head and get the magic in there. And there is a very serious point here, which is that motivational interviewing comes from a very good place, that where there's the conviction that the magic sits inside the person, and your ability to establish rapidly a quality relationship that brings the best out of them. But you wouldn't get that impression observing a lot of sports coaches or school teachers. So there is a serious question here. Now look, can I have the next slide? Okay, so here's something which maybe this is the early dementia on my part. It seems very simple to me, but I asked this question, what does it mean to be helpful? And I, in a way, wish I'd asked myself that question 40 years ago, because these are all well-intended efforts to be helpful to someone else. And my main message here today is that both motivational interviewing and giving advice can sit in that top right quadrant. If I ask you to go to the next slide, it helps me anyway. You can see where Chris Butler was. He was uncaring. I mean, we might argue about that, but it had that bottom left feel. And that phrase deficit detective works very well in sport when I work with coaches. They recognize that inside themselves, and school teachers, they recognize it. No, not like that, like that. Like there's something wrong with you, and the best way to change is if I point it out to you, tell you how to rectify it. And it's bottom left. Doesn't recognize people or work with people's strengths. Raises the question, what's top left? what's top right, and I'll fill that quadrant in for us a bit later, my thoughts about it. Okay, so I'll get on to that. But then there's another very simple model which we came up with 20, 30 years ago on the next slide, which is this distinction between different communication styles, each of which can be helpful in everyday life and at work. And each style can be used skillfully or less so. Could say what Butler was doing was using this style very unskillfully. But I have seen this used incredibly skillfully in some sporting settings. So, and the best advice I've come across was a health visitor in a South Wales, quite a deprived community in South Wales, who ran to the front of a workshop and said, I know, I want to stand with 2 feet firmly in that middle guiding style and move either side as necessary, which sounded like a good answer to the question about helpfulness. But that because her central position was going to be one of being a guide who encourages others to change. And, you know, looking back, I feel that motivational interviewing is really just a refinement of this natural style, which you can observe in the attitude and behavior of a mother with a very young infant. You can see it. Good sports coaches and school teachers have this as something that feels natural to them. But motivational interviewing itself, shall I kind of whip through 5 minutes of what it is? I don't know whether it's worthwhile. Do I need to? Okay, you cast aside labels and judgments, and you're speaking to a person who has strengths, not someone with this or that problem. And you connect well by listening. And that question about how do you listen well in just a few minutes has been a subject that I've focused on in emergency medicine in lots of settings, and it can be done. But it's very simple, but not easy. That's the conclusion I've reached. It's simple, but it takes skill to do, like a footballer will say, kick a perfect free kick, a soccer player. Well, what he's doing is very simple, but it takes skill and practice. So you connect well with somebody, agree a focus for change with them, not impose it on them, and then evoke or elicit their own good reasons to change and how they might go about it. And that's very different to client-centered counseling, where the conversation can drift any way that the person requires. This is quite focused and focused on the agreed direction of travel and on their views about why and how they might do it. Ambivalence is very common, and that's where we've gone into quite a lot of detail about how you respond to it. And you end up trying to work on a plan together. You can spot where advice giving could come in. Yeah. So basically, it's a sincere and curious effort to help people tell us how and why they might change. So that sounds like 45, 50 years of my life, and my apologies if it's so bloody simple that you think, what has this idiot been doing for all these decades? But I could put it in fancier language, okay, and drop you into the detail. But like, that is how I tend to see it. You know, simple questions like, why might you think about losing some weight, for example? How might you go about it? That's very simple. It's not complicated. But you just don't want to get in the way of somebody trying to find the answer to it. You search for it with them, alongside them. Boy, oh boy, that's relevant in sport, I notice. Wow. Wow. Now I thought, it's funny, I thought about showing you a video of me, and I don't think we've got time, and I don't want to see it. You don't mind. I think I came across this transcript, which I think I worked up with Bob Mash like 20 years ago. And I believe we were in, Bob will probably remember better than me. Okay. But just take it from me, this is not an actual consultation. This, I think, came about when we recorded some nurses interacting. It was in the HIV days, around 204, 205, I think, round about then, interacting with a patient in a rural setting. You got a picture of a rural clinic. Now I'm going to show you a transcript of what was recorded as an example of motivational interviewing. And let me just show you the next slide and give you a moment to read it. Okay. I'm assuming the remote people can do that.
Yeah.
Can they? Yeah. Yeah, if you could just switch on, excellent. There you go. Okay. We could ask, what style is that nurse using? And I'd say it most closely resembles a guiding style. Yeah. We could ask, what is her attitude towards this person? And I would say she's not viewing this patient as somebody with a whole lot of deficits and problems that need fixing. There's something deeper going on there about respecting this person as a human being with dreams and strengths like the rest of us, I think. And even a pleasure to see you. Okay, which is in a way, a vehicle for love, to be blunt. Her skills, it's a very normal feeling sounding conversation, doesn't it? Doesn't sound like a psychotherapy session. And that's interesting. But then a footballer kicking a ball into the far right-hand corner will say the same thing. It's very normal. It's a ball game, you know what I mean? Yeah, it's not something incredibly fancy. But where does MI come in? That's an interesting question. Because for me, this is pure MI, and it takes 90 seconds. So there's a good question. What do you reckon? I mean, I'm being a smart ass now because I know the answer, okay? But I thought I'd give you some space to. Where do you think MI comes in there? Because that's just, it sounds like a normal conversation.
It operates within the attitude of the practitioner.
So you see that in the attitude? Almost like that the answer to a lot of the questions are inside you. Yeah, you can see that. What else do you notice? Can you speak loud?
Sorry, the practitioner immediately hooks onto what the mother raises. I must do this for my baby. So she immediately, often what happens, what's the first things that people say are the most important.
Yeah.
And then building that as an asset-based approach.
Yeah.
The practitioner also gives the mother autonomy to guide what the conversation should be about when they ask what would be most helpful.
Yeah.
So what's important?
That's quite skillful, that bit, isn't it? Yeah. This here. Yeah, it's quite skillful. Yeah. What else do you notice? I'm not saying it's a perfect interview.
even though she says, let's talk about the medication, she still keeps the others as important. Just very skillful as well to say, okay, let's talk about the medication and we'll come back to the other things. So she hasn't put the other things aside.
Put it to one side, yeah.
She's kept it in play.
Okay. So now between that and the next slide, which is the same, I've just highlighted a couple of things. It could be a 2-day workshop on all of this stuff, right? If you could turn to the next one, maybe I'll just go through and highlight a few things. In motivational interviewing, you're incredibly sensitive to and aware of what we call change talk, which is the person's own good reasons to change. And here you have somebody who's expressing change talk right from the off. Okay, and there's a guideline, I think, which is that when you hear change talk, listen, don't change the subject. Okay, which is what happened immediately afterwards. That's a reflective listening statement. Yeah. Because it's like blowing smoke into a fire, you know, to make it warmer if you're cold. Yeah. So there's 2 of these statements in a row. Look, that you could say is very rapid and that's engaging. Okay, the 2 of them coming together. The next one is the task that we would call focusing, which is what you identify. What would you like to talk about? Now, that's focusing, and there's an agreement that they want to talk about medication. Okay. Then the next bit is effectively what we call the evoking or eliciting task. Where what is it about the medication that you want to talk about? Why and how do you want to change? Planning is the last of these 4 tasks in motivational interviewing. So we could pull this apart and, you know, drop into quite a lot of depth here. But it's a normal, elegant conversation driven by the use of a guiding style with very careful attention to someone's needs, someone's strengths, and using skills that bring the best out of them. How's that? What did this nurse not do is a question we could, long list what this nurse didn't do. Okay, so there's a quality of sitting on her hands. It's maybe a nice metaphor. And we could make a long list. And I think the skill is in that, which I see in athletes as well. The skilled ones know what not to do. They've got that clear. Yeah. And when they break it, when they violate that, they hit trouble. Tell you some crazy story. Because one guy always keeps going out for 49 or 93. What's going on there, right? He sees the milestone approaching in his cricket, yeah, and he starts violating. Okay, so what the nurse didn't do, there's quite a lot of restraint there. Okay, now look, can I move on and try and bring advice giving together, or I could stop for questions? How are the guys in the remote thing doing? Am I being clear, or are you guys all right?
What's one comment in the chat by Steve, but I don't know if you want to address it now or later.
It's not Francois.
Not
Okay, I'm very disappointed. Steve, shall I take a check?
Yeah, we're good. The joint agenda between the patient's and the doctor's agenda is a sort of model that we were taught in family medicine years ago. How does that differ? Is it just different language for the same thing?
Totally. Yeah. Yeah, we were using, looking back, I kind of feel that it's maybe a bit too much jargon. Agreeing what is a useful focus for the discussion is a simple de-jargonized way of putting it. Okay, Steve.
Yeah, and Hoffy's asking, please talk about advice.
Advice. Advice. Yeah, I'm coming on to that. Can I? Yeah. Is Steve happy? Whoever he is.
Steve looks happy.
He's happy.
Steve's very happy.
Okay, good, Steve.
I love the skill because she never took the bait about the condoms. She still waited and she still asked. Whereas I would have gone for, oh, tell me more about that. Or what do you think about what's going on there? And so still thinking I'm opening the conversation, but I would have gone for the bait that she initially threw. So I just admire the restraint she did. She's still taking a step back to check, is that what you want to do? It might also have been something at the forefront of the patient's mind, but I think in allowing her to hold the perspective of what would be most valuable now,
Exactly.
put the power back in her.
Was this person trained?
Sorry.
Was the practitioner trained in motivational interviewing?
I don't know. We'll have to ask Bob. We'll have to ask Bob. I think we were training at the time. That's my memory. Yeah, it's stunning. And there might have been some adjustment in it for dramatic license. So quite possible, yeah. But I agree. I think that is a stunning example of restraint. And you see the beauty of that in a skillful teacher, in a skillful parent who's watching a kid make a mistake, in a skillful sports coach. You see the beauty of that restraint. Just because there's a problem doesn't mean you jump in on it. Yeah, that's for sure. Okay, Steve, I'm coming on to advice, okay? Can I move on? Yeah. Okay, so look, this is a simple map that we put together for how you might give someone advice, okay? And this had different words over the years, but this is simple and de-jargonized, okay? And let me just go through each of the elements in turn here on the next slide. Because if I've had a sort of a eureka moment about this, I think it's this slide reveals it, which is if you ask about what someone would like to know, could know, or ask their permission before you give advice, makes an incredible difference. Now, my kids get cross with me and say, your dad, stop asking permission, right? and they mess around with it. But actually, the principle of it is very important. It's that moment of restraint. Would you like? And it puzzles me how we haven't been trained to do this. And I think this map can be useful. Then this is a very simple skill set in which you offer up rather than dump down. And that shift is quite a big one. Offering up means you are showing respect for somebody, almost like you coming in with, would you like a plate of them? Would you offer it? They might or might not want it. That's a very different attitude. The language is tailored accordingly. So there's understated language. You might do this or you might do this because that's the autonomy and choice that you were noticing in that other consultation, where there was a similar use of, yes, we can come back to that later if you want to. Yeah.
I'm also hearing offer here as an invitation.
Say that again.
So I'm hearing offer as an invitation. So
Yeah.
think about invitation, you could either accept or decline.
Yeah, correct. It's a big shift. for a lot of people, yeah? And then ask them what sense they make of it. Now, I could demonstrate that now. Steve, I could demonstrate it. I can live and breathe it, as I bet you guys can as well. With just a little bit of adjusting, I bet you can do it. The question is, where does motivational interviewing fit in? And on the next slide, I just crudely, yesterday, thought I'd share with you my understanding of it, which is that in questions like that, the answer to those questions is change talk. Can you see that? Yeah. People will tell you what they want to need and why they want to change, what sort of help they need. The moment you ask questions like that, you're in the world of motivational interviewing if you want to. Okay. So if I could have the next slide. I thought I would, so that's actually the most important thing I wanted to say, what I've just said, which is that when you give advice skillfully, motivational interviewing and giving advice are part of the same activity. Okay. So now we've got to go back and try and make some sense of what happened in William Slater Hospital and what we observed with Nutcase Butler being the deficit detective, okay? And I think this helps us, or it helped me anyway, which is in the bottom right here, you've got basically a smooth operator. You could call him a clever dick or whatever you want to call him, right? But somebody who strategically manipulates people for certain ends. Okay. And there are forms of therapy and there are forms of all sorts that actually champion that, I'm afraid to say.
I think oftentimes our students are rewarded for being that smooth operator.
Yeah.
In oral exams.
Yeah. Oh, I'll tell you a really weird one, right? This daughter of mine, this is completely bonkers. This daughter of mine, she's 23. I taught her to use those kind of listening statements that you saw in that thing at the age of 7. Okay. Not because she's my daughter, but kids are much easier to teach empathic listening to than adults because they're curious. So you can teach them the skill, and they should be teaching the kids this skill in school. But so this kid, she knows motivational interviewing. She has conversations with better quality reflective listening than I can. She's that good at it. She never failed anything in her life. Right through school, she was a high flyer, right? Worked really hard, very competitive, engaging character. So she gets to her final year medical exams, and I'll tell you the story, right? She gets to her final year medical exams, right? And she gets distinctions in boom, 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 top 8%. But what happened? Yeah, the OSCEs, you know what the OSCEs are. You use the same language here. 12 or 11 OSCE stations, distinction in all except one, where she failed for the first time in her life. Guess what the station was? The rest of us have just fallen around laughing. We think it's good for you now. Yeah, you think you know it all, right? But she's taken it well. But yeah, that was weird. Something went wrong there. I could explain why, but we think that's hilarious, and she's taken it very well. Yes. Okay, the smooth operator, then next slide, bottom left, that's the deficit detective, right? Who instead of seeing people's strengths, sees their weaknesses as the foundation for emitting expertise. And I see this, try to use the metaphor of a lens. If the lens you're looking at people through is to do with deficits, you'll spot them everywhere. But if the lens is looking at people's strengths, you'll notice things you haven't thought of before. Now, I've even got a sports coach he's an Aussie, he works in New Zealand at an elite level. He turns up with the coaches with spectacles now, having picked up this metaphor from me. Red and black. The red ones, you're looking for strengths, and he makes them wear the spectacles and go and coach. It's interesting. And the difference is phenomenal. The athletes love it, and the coaches get confused. Where's strengths? Where's strengths? Because they're so used to seeing deficit. Yeah. Okay. What about top left? I think that's where most of us are.
Mhm.
Yeah. We're kind of I am certainly enthusiastic, using the fixing reflex. Yeah. Yeah. You don't have that restraint that we saw. And then finally, top right. We can imagine that nurse going on to do just that with that woman. You can imagine it. It's not complicated. So look, by way of conclusion, Steve, there I've tried to describe. You can see the mistake we made in motivational interviewing, Butler and I, which was we assumed that advice giving was that. That was the mistake we made. We didn't realize that it could be that. You see what I'm saying? And that was a mistake. So just by way of conclusions, I think that's the last slide there. Oh, I didn't put them up. I don't think. Let's see. Next slide. Oh, no, I didn't. Okay. Look, can I put it this way? From the perspective of advice giving, if you would someone say in a consultation, if you find yourself wanting to give advice, you can do this respectfully and offer them choice in a very effective way that makes it easy to use motivation, to easy, to just flow naturally. If, on the other hand, you're using motivational interviewing, opportunities to offer advice crop up all the time, like we saw in that. So either way, you should be able to merge these two. And I guess for me, the motive for coming here and doing this today is to ask that what if question. If this kind of simple approach to offering someone advice in a respectful way had been operating down there in Rondebosch Common, would it have been different, the outcome? And I so strongly suspect it would have been. There you go. I think I'll stop now. And I'm just hoping the fellas who remote have enjoyed it as well. I'm sorry if I wasn't able to look at you in the eye. I think I'll stop there because it's 2 o'clock. I'm sorry I didn't leave more time for discussion.
There may be a couple of questions, and people can say, how is your time? Where do we?
Another 15 minutes.
Oh, brilliant.
Yeah, if there's any reflections or contributions.
Yeah, Steve, other Steve here.
Yeah.
I would have added a axis of listening versus talking. You've got caring, uncaring. I think everybody wants to care. I don't know that people take on this sort of job if they're really uncaring, but some people just want to do a lot of talking and no listening. And I think it's not just listening to the words, it's listening to the body language and taking into account the context and how you've known the person before. So it's a whole lot of things that go into listening, but taking that on board, especially in the first 30 seconds of the consultation. So yeah, it's different words for the same thing, I think.
Yeah, and that matrix came about when I was working with a group of cricketers and asking them what a helpful coach is. Helpful coaching is, and I went home and drew that. But I think you can play around with that matrix and use loads of different words for the axes, as you're suggesting. There's no one that's more useful than another,
Yeah.
In fact, probably the best axes are the ones that you create personally for yourself.
Agreed.
Yeah.
Another hand from Ishak.
I just ask, so for me, a really important part to this is the clinician's self-awareness
Yeah.
and not jumping to conclusions
Yeah.
and assumptions about patients.
Yeah.
So, but that's not specifically often sort of like referred to. I mean, we talk about our behavior and watching it, yes, and how we listen, but it's still the
Totally agree. Yeah. I think it's under-emphasized. And like the phrase I use in sports, is take a look in the mirror. I had a session yesterday with the Football Association, hundreds and hundreds and hundreds of coaches that they wanted to develop. What's the number one thing? And I said, look in the mirror. Start there. Yeah, couldn't agree more. Because until you have that self-awareness, you're not going to be able to manage yeah. And it's interesting how we didn't quite kind of emphasize it.
So I think on this, honestly, our training almost like this incentivizes that. We're just so focused on the other that we actually sort of almost kind of lose track on actually having to like put a little bit of focus on ourselves as well. But it's, and we start already with that focus on the other, on fixing the other, all of that, and then we kind of lose track of ourselves. Yeah.
The consequences of failure to develop self-awareness in healthcare are catastrophic, I think, in some circumstances. There's a whole movement in the UK NHS that I find very uplifting called Civility Saves Lives. You maybe want to have a look at the website of that. Civility Saves Lives. Chris Turner is an emergency medicine physician who founded that. He came to see me in Cardiff a few weeks ago. We sat on a bench. And I said, Chris, where did you get the phrase civility saves lives from? Because I said, man, I spent decades trying to improve communication in healthcare and I got nowhere, right? And this is transforming. People are asking for civility training, okay? Which is interesting because rudeness is so widespread, which we know in healthcare, and the lack of self-awareness, right? So I said, Chris, where did you get the idea from? And he said, Steve, you know where it started? I called it Don't Be a Dick. He says that. I said, serious? He said, yeah. And then we decided to flick it around to civility saves lives. But, you know, this is not an academic. Chris is deals with trauma and emergency on a daily basis, and he's a high-end practitioner and consultant. And he speaks passionately to the importance, not just of being polite to people, which is what civility suggests, but of having self-awareness, showing people respect, and asking for feedback as a leader, which is what he talks about. Is there a question here or a comment here? And I'm so sorry if we completely ignored you.
Ishak, the days.
Yeah, thank you so much. Very insightful. I really appreciate the talk. I mean, so I teach health promotion and behavior. Trying to get people to change behavior is one of the challenges, and I think motivation interviewing can certainly play a role in that. So I just wanted to ask. I mean, I am aware. First of all, just to say, I haven't formally trained in motivational interviewing. I think that's a gap that I need to fill. But and I am aware that your stages of change model can be used in motivational interviewing. I wanted to just ask in terms of other behavior change models, like, for example, the health belief model or kind of other kind of social models. Do you use that in your application of behavior change practice? And also another question would be, I mean, behavior change is very well suited at an individual level. Are you able to apply it at a group level or at a population level as well?
There's a lot of questions there. The stages of change model is like a contented cousin of motivational interviewing. And I have been quite close to Carlo Di Clemente. I haven't seen him for a few years. It's just a useful way of thinking about why you speak to someone the way you do. So any model or theory that you think you can put into practice in the interest of having a constructive conversation, go for it. There's no hard and fast rule. I'm certainly don't see myself as somebody who should even think about that. So yeah, the health belief model, if it helps you make sense of the person you're speaking to, fine. And the stages of change model, we go back a long way together. And it's useful. What was his next question? Was equally complicated.
Can you do motivational interviewing on a mass scale, on a group scale?
I know Bob Mash tried to develop this 20 years ago. I feel it's a huge potential value in group educational settings. And if you think about the topic of today's talk, the merging of motivational interviewing and giving information, there's nothing like an educational group to actually do that. Having said that, the skills involved, it's a little bit more difficult because you've got all these people in the room. It's not just one person. To be restrained in the way that you've identified is more difficult if there's a group. But I think the ask, offer, ask model does provide a potential framework for a group educational process where motivational interviewing can naturally help. But I must say, on the other hand, if I look at what goes on in sport, can I tell you, I'll just tell you a sports story. He used to be the England head coach. Okay, so this is somebody who knows his stuff. He's a lovely bloke, absolutely lovely bloke. He would agree with you about self-awareness. He would agree with most of the things we've been going through. But he says to me the other day, we've got to get some of those senior players to shut up, okay? Because the younger ones are not speaking up, okay? And we want the player's voice. Okay, we want the player's voice now. We go into the meeting to get the player's voice. He starts with a brilliant open question. Okay, he starts, right, I want to know what you players really feel about what went wrong yesterday. Brilliant. Okay, but guess what happens, right? The senior blokes speak up. The rest don't say anything. One guy says something. Then he moves on to the next guy. And so when the one guy says something, the thing to do there is like to offer a reflection statement. Okay, because then she might turn up with something. Now that's highly skillful, right? And instead we got the complaints about the senior players whom, you know, when there's silence, the senior players, the senior people are going to speak up. The people with authority are going to speak up. So it does take skill, okay? But I think it's well worth it. I'm describing the skills in an open-ended group situation, and I wouldn't recommend that. It's so difficult. I think to have it nice and structured, using something like ask, offer, ask, you can get away with it. But to have an open thing, more difficult, more skill. God, I'm talking too much.
How much does this vary according to where the person is at? I'm thinking you're speaking about an emergency situation, emergency in ER, and then the person is very anxious and overwhelmed. That's a more difficult space for somebody to be dealing with open questions. I'm thinking of another training where I've been direct, protect, connect. That was training around disaster management. Protect, you know, it's very focused. So how does one moderate depending on where the person is at? If
I wonder if the people remotely heard that, because I think it's a fascinating question. In other words, in a very tight and difficult and potentially traumatic emergency medical situation, what sort of conversation is helpful? And I noticed with myself, I had a heart attack in 2018, okay? And my son was with me in the bed when the lovely cardiologist came round, then says for like weeks afterwards, but he told you. Why can't you remember, you idiot? Don't you remember what he said to you? And I said, no.
To your house.
Yeah, I was zoned out.
So,
Wrong time, probably wrong way, although the guy was so sweet and well-intentioned.
If I can maybe just respond to that. I mean, we've been teaching communication skills in family medicine for many years. What's become apparent to me, well, it should have been apparent maybe much earlier. Took me a long time to learn this lesson. Is that the type of conversation we have in a primary care context is vastly different from the type of conversation you'd have in an ICU. Your underlying motivation may be the same.
Yeah.
But the form of the conversation must match the context in which it's being held. You're not going to, if you're teaching your daughter how to drive, and she's about to cross a red light, you're not going to say, do you think doing this? Like, I'm not going to ask, can I offer you some advice in this moment? So I think the context in which the conversation happens necessarily, and it sounds like an intuitive thing to say, but I'm guilty of approaching my teaching in this regard almost from an ideological perspective. Like, we must be patient-centered, we must be empathic, we must ask open-ended questions. And in real life, that's not like a realistic way to approach things. It's almost like there's a common sense phronesis that we need to apply in how we communicate.
Conversation is meeting the patient where they're at.
Yeah.
Because they are more experts in their diagnosis than clearly that they know what's been going on. Cultural competence as well, because there's ways in which they would explain what is going on than how the physician would generally know.
There's sensitivity to that in what you're saying, which is be flexible and be aware that people. And I did wonder whether if that. I don't want to criticize the cardiologist because he was a really lovely bloke. I subsequently met him in a cafe and thanked him. He was a great guy. But what if he'd said to me, what would you most like to know now? The opening of that ask, offer, ask. What if he'd said that? And I would have said, I'm so sorry, I'm zoned out. Can you speak to my son? Okay.
Yeah.
So I think the ask, offer, ask is very simple and elegant. It allows you to maybe understand what someone needs quite quickly.
To come back again to ourselves, and you're saying to meet the patient where they're at, but also to ask ourselves, where are we at the moment, and am I in the best state to be having this conversation with this patient?
Yeah, it's like me saying to that cricketer, how useful might it be for you to have a psychologist at last thing?
Yeah.
Just there about did you call it a change question or change?
Change talk.
Change talk. I love that. And I think maybe in that emergency environment, whatever, it's just to facilitate kind of what's happening with that patient. Because that moment, obviously depending on the diagnosis or what's going on, might be a change moment for the patient. And maybe our only role then is to create a little bit of awareness around what is going on here. And I don't know how we would phrase that, you might have suggestions, but so they might not realize this is a brick wall for my alcoholism or my domestic abuse or whatever. So how do we facilitate that perhaps the patient can see that this is the change moment for them, or when they should start to think about change, like how is this making you feel being here on a Saturday night, having hit your head from drinking too much alcohol? I don't know. That's what I'm taking. Maybe in that scenario, it's more about, are we guiding the patient to recognize that this is perhaps the change moment? Yeah.
It's tricky judgment, eh?
Because we might see it as that and they might.
Yeah.
So I think on that note, I just want to thank you. I see Ishak has got his hand up. Is it the final remark? Was the old hand, new hand?
Yeah.
Final words.
Sorry, I just wanted to comment on the ICU context, which is where I often find myself, having to speak to patients. And I think that the motivational interviewing techniques, or the little that I know of, I find it to be of potential use. Maybe to start off with a question like, what do you understand is happening with your relative, or what do you understand is happening with you? And then to use that as a way to kind of guide where the conversation might go, and it might lead to what are your concerns, and continue in that way. I mean, it might not be. It might be an opportunity for a cue to action. So, what do you think of? I mean, what do you think might have led you here? And maybe the person might speak about the smoking or whatever other habit, but it might not be the right time also. So one has to kind of gauge where the patient is and what mental frame they are in at that intense time.
And be aware of personally what it is inside you that's making you say what you say, which is.
But you're also saying whether that first ask would be towards your end at yourself.
I think that will be really emphasized because of the context that we often work in, which can be very pressured. And then just to know that, are we going to be in our best sort of space to be having sometimes very difficult conversations with, especially people from ICU. Yeah.
Great. So hopefully some of you will be available to join us in a week's time for an afternoon session where we will be able to build further on this conversation. But for now, thank you, Steve, for making yourself available and for sharing this fresh take on a concept that has clearly been with you for a few years. But it's lovely to also hear how over time things, like you say, become simpler. And it's good to put it in that way. Yeah.
And let me know what can be helpful next week. I don't know.
I hope some of you will be able to join next week. Yeah. And those online are also welcome. Thank you.
Yeah, fantastic. Yeah, next week. Just before we come out. See, yes, on making the linkage.